Thank you, Katie, for having me, and thank all of you guys for taking the time to join us this evening and hear a little bit about acute kidney injury and some of the things that I've been kind of looking at with this. So my history is I used to be a special operations medic in the Army, and I worked over at Civil Affairs, the Special Warfare Medical Training Group, and over at JSOC. And basically, the way I started with this was I kind of looked into the injury prevalence of people as we saw them early on in combat, 2001, 2002, and 2003, both in Afghanistan and Iraq. We had a lot of patients that came in that had what I would think were pretty straightforward injuries, but would have long-term stays in the hospital as far as recovery post-injury, and kind of piqued my interest. And I started coming back to some of the same issues between multi-system organ trouble or disease, as well as acute kidney injury. So I'm going to go ahead and start sharing my screen, and we'll just get started a little bit into this. Right, Katie, can you see it?
Yes,
Okay.
I can see it.
Okay, so I've already kind of given you guys the little intro. So we're just going to basically review, just do a quick review of the kidneys, and then why I kind of looked into acute kidney injury and some of the research interest that I have on this, and then some of the patient population and factors that are contributing to what I believe is occurring with kidney injury post-combat trauma. So real quick, as we all know, the kidneys are part of the urinary system. They eliminate a lot of the organic waste through our urine. They adjust blood volume and pressure by regulating the volume of water loss and release through the release of hormones. And they regulate our plasma ion concentration, stabilize our blood pH by controlling the loss of hydrogen ions and bicarbonate ions. And this is really important, especially since we've adopted the use of fresh whole blood and low titer O. It's so much more important to have the blood products to replenish and hopefully prevent kidney injury. As we all know, a lot of the crystalloids can cause the swelling, which we can end up having systemic inflammation syndrome. So conserves nutrients like glucose, amino acids, stuff like that. So there's a little slight difference between acute kidney injury and acute renal failure. So I put the definitions up here for you, but essentially it's based on the changes in the serum creatine, urine, urine output or both. So, and then kidney failure develops rapidly over a few hours to a few days, and the kidney failure is most common in people who are already hospitalized, particularly with a critically ill patient who needs intensive care. So, why AKI? Well, acute kidney injury after combat trauma occurs in up to 34.3% of most critically injured patients, usually within the first 2 days after injury. In future operations that the military has forecasted in multi-domain and near-peer and peer-to-peer conflict, we're going to have prolonged evacuation times. So you're going to have to sit on a patient a lot more. And in doing this, this could also translate into several different natural disasters. If you look at earthquakes in Haiti, or even hurricanes in like they had in Houston and whatnot. If you if you can evacuate a patient, this is something that early on start thinking about in your treatment and how they may affect later on. So AKI after combat injury was associated with hypertension and chronic kidney disease. Stress on the kidneys actually starts before trauma, and I'll show you why in here in a second. When you look at this, why did I say that the kidney injury starts before the trauma? Because most of the time in the military, our patient is between 18 to 40 years old, and most of our patients have a patient history of, or a culture of drinking in the military. So they probably, had, a lot of liquor in their past, and then, they do physical training. They may be on some type of sports supplement. They might have been a prior heat injury or had a prior kidney injury, whether it be diagnosed or undiagnosed, because some people can push through mild heat injuries or mild kidney injuries. And a lot of times, you have a medic, or they may just say, I just need to hydrate, and they work themselves through it. So they actively dehydrate themselves as well. So a lot of times you have people that don't want to, you have to urinate during a flight to Target, or, drive an logistics run or whatnot. So they actively dehydrate themselves so they don't, they're not that person. And then they also consume as I covered before, the high dose caffeine or pre-workout. And then who knows what other type of supplementation they may be using. So what are some other potential factors? Currently, if you look at a lot of the medications that are authorized in both the clinical practice guidelines for anesthesia, as well as PFC, you'll notice that there's a lot of nephrotoxic drugs. This isn't necessarily a bad thing. You've got to excrete, the drugs have got to be processed, someplace, and they've got to be excreted out. But these are just things to consider. This is not a one-shot solution. These are a bunch of factors that contribute, and if they all align, it could put our patient in a bad place. So one of the things I want to discuss with us afterwards is which of these are we going to actually be able to influence. And as we think about creating future protocols in the future, have this in mind as to what you're actually putting together. So volume overload. If you get evacuated, you might be, hypotensively resuscitated to a certain point. If you get into an FST versus a cash, the amount of fluid that they use during a surgery may differ. And too less of fluid, and you're causing stress on the kidney. Too much fluid, you're causing stress on the kidney. Then you add the insult on top of that. So the recognition and detection. If we start thinking about this early, it's a lot better than later, because as we talked about it before, the hormones and the influence of the kidneys on everything from blood pressure to the release of different hormones, it's essential to the body. The current impact of the blood protocols being utilized, I covered a little bit earlier. I think it's a huge positive in the success in combating acute kidney injury. So, so what I mentioned here in the fragmented evacuation system, this is mostly for initial entry operations, or where you're conducting small relief, missions, or even if you're doing a humanitarian thing away from a lot of different people, you may not have the evacuation assets. So this is just a quick sample of a couple of the drugs and some of the pharmacokinetics and considerations as you went ahead and used different types of medications, everything from barbiturates to muscle relaxants, and some of the volatile anesthetics. Like I said, this doesn't mean any of these are bad. This is just to start bringing some concern, and just like I said, there's a difference between concern and being alarmed. Just as you manage your patient, understand what you're actually giving and the impact that it could have, because that might give you a high index of suspicion, as I'm bringing up here, the awareness of where your patient's going to be going and what's going to be happening internally. And I kind of mentioned this during the first few years of the current conflict. There was no joint trauma registry. It didn't really come on until 2005. Now we can look back, to see what was documented and what the prevalence was of the patients that came in with trauma, and whether or not they and when they developed AKI, if at all. the other concern is we rely on a lot of the medics out there to make that cognitive leap. If you have a patient that was in a rollover vehicle due to an IED, you might be trying to interpret, go between your burn, critical practice guideline, your CRUST syndrome protocol, and your acute kidney injury or acute renal injury within the same patient. And a lot of times, the protocols and policies and algorithmic driven approaches at times in the pre-hospital medicine arena don't consider the impact of combining all those treatments and what that might act and how it might influence the kidneys. So, a lot of our focus to this point with the kidneys has all been reactive. A lot of people are used to using a urine dipstick to check to see if the kidney levels are bad, or to look at the color and consistency of the urine. So some of the things that I think that we can impact is, we can identify, service members that are at greater risk prior to sustaining combat trauma. This is, simple as trying to do some behavior modification, make sure people are hydrated, or it could be they require prior heat injury. In the regular military, they do this, but it's not a consideration on whether or not they're mission ready or where they're really at. And nowadays, with a lot of the fitness devices that are out there, you can even look at heart rate variability. So one of the things that I think we should look at also is identifying the current resuscitative intervention and protocols and seeing how we've actually fared with them. And if there's a way that if we modify one or two things, we could increase the prevention of acute kidney failure or renal failure, excuse me. And can biomarkers be used? There's been a lot of developments in the biomarker arena as for early detection. And there's some that are I think more prevalent than others as far as being accurate. But it's up to the nephrology community to hopefully point us in that direction as to which ones would be the most accurate and within our means to be able to utilize. And this, in my opinion, would be more for the prolonged field care, extended care type of setting. So what do we know about AKI? Acute kidney injury was associated with 66% increase in rates of hypertension, nearly five-fold increase in chronic kidney disease. The current CPG 52 is the one on hyperkalemia and dialysis for the deployed setting. And the casualties risk increase mortality and morbidity with AKI. So our current method of diagnosis, I kind of covered. We basically use the RIFLE acronym, which is the risk, injury, failure, loss, end stage, and the AKIN, which is the acute kidney injury network. This one shows the one of the AKIN, which is the serum creatine, and looking at the elevation of the levels as well as the decrease in urine output. So question 3 goes back to the other one that I asked earlier, which is using biomarkers like insulin-like growth factor, binding protein 7, or tissue inhibitor of, I always say this wrong, the proteinase, to detect kidney stress. Can we decrease AKI? And in the graphic shown below, you've got your normal kidney, and then you've got your at risk where you're asymptomatic, but it's starting to stress. We can do this on a normal basis, just with different workouts we do and different diet. However, if we can detect when the kidney is becoming stressed, we can hopefully reverse or inhibit that stress before it gets damaged. Currently, we're looking at the urine output and serum creatinine levels, which by that time we've already had known kidney dysfunction and the decrease in the function. So at the end of the day, it's all a balance. Good medicine, what saves a life today, they may develop or have a problem later on, but hey, they're alive. And, we've just got to balance everything out. But as long as we're aware of some of the things that are out there that we could potentially be doing, we might be able to avert them in the next round of protocols, or how we actually look and treat patients when we see them within our environment. But that's all I got.